There's been considerable data now that aspirin seems to reduce the risk of developing colorectal cancer. But I think there's less clear data as to whether it might have an effect that reaches beyond the colon. So we really conducted this study to understand, does aspirin potentially impact an individual's overall risk of developing cancer? And if so, what particular cancers are affected? And so what we found was that aspirin does reduce the risk of colorectal cancer, but does have a significant benefit for overall cancer, although largely that is driven by reducing risk of colon and other gastrointestinal cancers in particular. So we included men and women that were enrolled in two large prospective cohorts. One is a nurses' health study, where we've been following over 121,000 women since the 1980s for the development of cancer and other diseases. And also the other cohort was a male health professionals follow-up study, where we've been following almost 50,000 men since 1986. So in both of these cohorts, these men and women have given us very detailed information on their use of aspirin, and also whether they've been diagnosed with colorectal cancer and other cancers as well. So we were able to really connect this data with their incidence of cancer and really, I think, take advantage of the fact that they've been able to provide us such data over such a long period of time. Interestingly, the rates of colorectal cancer are actually quite similar in both of these cohorts. So overall, we think it's generally reflective of the general population. We do know that overall they tend to be a bit healthier in terms of their rates of smoking and also their likelihood of being screened for various cancers. So there are differences, I think, in this population compared to the general U.S. population. But surprisingly, they're pretty reflective of what the U.S. population is like. So dose is an important question. I think largely because the study was conducted through the 1980s and 1990s, most of our participants were using standard doses of aspirin because baby aspirin was something that really started to become popular in the more recent time. But we were also able to collect that information as well. So we really did see an effect of aspirin that seemed to stretch into the low doses as well. So it looks like both low doses and standard doses are effective. Overall, there was a suggestion that the more aspirin you use and the higher the doses, the more the cancer benefit. But I think that still is something that we need to investigate more carefully. The take-home message is that I think this adds to the body of evidence that aspirin really is effective in prevention of colorectal cancer, but I think also provides, some hope that this might have a population-wide impact. Clearly, the effect is strongest in colorectal cancer and in other gastrointestinal cancers, but that's still very meaningful because those represent really significant causes of cancer in the general population. So if you actually look at someone's overall risk of developing cancer, there's still a potential impact that could be felt. And so from a public health standpoint, I think the message is that we need to study this more carefully and understand how does this sort of add to other strategies for cancer prevention, how does it potentially augment the effect of screening and prevention, and also how does it potentially interact with the effect of aspirin and other chronic diseases. We know aspirin, for example, does seem to prevent the risk of vascular disease. So in combination, could aspirin really have a substantial public health benefit in that it does seem to have this benefit for the two leading causes of death in the U.S., which are cancer and heart disease. The issue with aspirin has always been its potential side effect profile. We know that aspirin is associated with a higher risk of gastrointestinal bleeding, and so that has created some reluctance, I think, in the general medical community to recommend it as a routine therapy, which I think is completely justified. I think we're still not at the point where we should be recommending aspirin for all of our patients. This means two things. I think one is we have to factor in this potential benefit, and so as we start to think about risk-benefit for individual patients, we should potentially think about not just heart disease, but also cancer as the benefit weighed against the risk. And also I think this increases the need for us to really develop methods for us to stratify individuals for aspirin therapy. If we can really identify which patients and which subgroups of patients may stand to benefit more, and also which patients may stand to potentially develop more harm, we can then potentially more personalize our delivery of aspirin to really achieve this goal of precision medicine, where we can potentially use a precision medicine approach in not only therapy of diseases but also prevention. We're definitely working on developing our study into a greater understanding of sort of the absolute benefit of aspirin in the context of both heart disease and cancer, but also a significant part of our effort is trying to understand on a molecular level how aspirin's working, and in developing that understanding we can better develop and exploit those molecular mechanisms to develop biomarkers to really identify subgroups that may stand to benefit.